A very good morning, ladies and gentlemen, and I welcome you all to Day 2 TOS Vision 2021. I'm your virtual host, Diksha Rana, and we'll be starting with the next session for the day at Dr. S. Badrinath Hall on glaucoma management options looking to the future. I would like to take the honor to invite our esteemed chairpersons. I welcome Chairperson Dr. Sati Devi, Co-Chairperson Dr. Sunita Dubey, and our moderator, Dr. Vanita Pathak Ray. I would now like to hand over to Dr. Vanita to please proceed with the speaker presentations. Over to you, madam.
Thank you very much, Diksha. Just like to share my screen first.
It's up, we can see your screen.
Yeah, just a sec. Go on to the slideshow. Yes, a very good morning to all of you. I extend a very warm welcome to the glaucoma session of the Telangana Ophthalmic Society 2021 virtual conference. The theme of the conference is technology and trends, and we have brought together for you an array of speakers, excellent speakers, who will highlight this in our glaucoma session, which is titled Glaucoma Management Options Looking to the Future. In this session, our keynote speaker has joined us live from Singapore, and he will discuss strategies to detect glaucoma in large-scale settings. This will be followed by a talk on the ever-changing technology of anterior segment OCT by Dr. Sati, and it will be followed by a subsection of minimally invasive glaucoma surgery as it is practiced today in India by surgeons who are doing it on a day-to-day basis. I would like to introduce the chairpersons first. We have Dr. Sati Devi, Head Glaucoma Services at Narayan Nethralaya in Bangalore. Her areas of interest are angle closure glaucoma, and as you I think all are aware that she's very experienced. She not only in glaucoma, but also in teaching, in academics, as well as presentations as faculty at national and international conferences. Dr. Sunita Dubey too, she is currently, she's our co-chairperson today, as Diksha said so. She's the medical superintendent as well as head of glaucoma services at Dr. Shroff's Charity Eye Hospital in Delhi. She also has extensive experience in management of glaucomas, pediatric, refractory, and she has special interest in glaucoma drainage devices and MIGS. She too has lots of experience in teaching. She has published in peer-reviewed journals. She has presented in national and international conferences. Additionally, she is member AIOS of the NABH, National Committee for Quality and Standards, and she's also member Task Force, Ministry of Health. She has received Women Achiever Award as role model in 2017, and has been the treasurer of Glaucoma Society of India 2012 to 2014. We also have Swati joining us from Pondicherry. She is a glaucoma consultant at the Arvind Eye Hospital in Pondicherry. She too has interest in glaucoma management, surgical glaucoma management, not only conventional trabs, but also the newer ones. And she's going to present to us on GATT. She has also received a lot of awards and publications. She has several publications. Last but not the least, our keynote speaker here, who's joining us from Singapore, Dr. Jayant V. Iyer. He is a consultant at the Singapore National Eye Center, clinical adjunct assistant professor at the Wilmer Eye Institute, Johns Hopkins, and as well as the Duke NUS School of Medicine at Singapore. He's the head of SNEC, Clinical and Service Quality, as well as the secretary of SNEC Global Ophthalmology. And although he's just put a point there, he is the founder, chairperson of the Vision Mission Singapore, which reaches out globally to to give ophthalmological services in needy and areas which are do not have access to ophthalmological care as much as what is available for him in Singapore. His areas of interest are surgical optimization, patient-specific quality of life, knowledge, attitude, practices, as well as global ophthalmology, as we know. He's been decorated quite extensively, and since the last time I introduced him, I see that he's added another couple of them. He's been the COVID Hero Award. He's been awarded COVID Hero Award in 2021 by the Singapore Health Services Distinguished Service Award, 2021 by the Asia Pacific Academy of Ophthalmology, Healthcare Humanity Award 2020 by the Singapore Courage Fund, Excellence in Ophthalmology Vision Award by Novartis, Distinguished Service Award, Eye and Vision Health Awards Singapore, as well as the Sing Health Quality Service Award awarded by Sing Health. He is author of Essential Ophthalmology, a guide for general practitioners, and has been nominated as an outstanding educator. So with these words, I invite Jayant, Dr. Jayant V. Iyer, to deliver his keynote lecture on strategies. I'm very sorry, I'll stop share here, on strategies of detecting glaucoma in large-scale settings. Jayant, all yours.
Ladies and gentlemen, thank you very much for having me at your esteemed conference, Telangana Ophthalmic Society, Ophthalmological Society. Thank you for inviting me, Dr. Santosh Hanovar, Dr. Vanita Patakre. And of course, it's really my privilege to share the podium with many friends and esteemed colleagues, Dr. Sati Devi, Dr. Sunita Dubey, Dr. Swati Upadhyaya, all of whom are friends. And it's my privilege to be here with you on a Sunday morning / afternoon. And today we are going to, and thanks for the kind words of introduction, Vanita, as always. I think, let me just move along as to what I'm going to be discussing today. Basically, my aim is to set the stage for many of the wonderful talks that are coming ahead for you to detect and manage glaucoma in a large scale settings. Sorry, it's glaucoma with an M. I was asked to keep this relevant to India. So for example, I think, first of all, very well done to the Indian Olympic team for getting the best medal haul in a long time. I think especially the hockey match was riveting, and it got me back to my old love for hockey, which I used to be a school team player pre-medical school days. And I think what we can say is India has done well, but there is still a long way to go. There are miles to go before I sleep, as Robert Frost put it. And similarly for glaucoma, we have come a fair long way, but there are many things that we can do. And I think the solution is to work in a systematic, structured manner to catch this thief of sight. I have no financial disclosure relevant to this talk. What is the scope of my talk really? If there's no definition, how can you detect a disease? So what is glaucoma? What is the current status of glaucoma and the challenges we face in detecting and managing the disease? What are the strategies we have currently? And what are the strategies we have currently to detect glaucoma, to treat it and manage it both currently and in the future? What is the direction we might want to take? So definition, what's the point? So you might ask, definition allows public healthcare experts to identify, assess, and treat a condition. In 1991, glaucoma was not even listed as a cause of blindness on many official publications because, as one expert stated, it cannot be defined or treated, so it's not on the list. So I think it is important to have a definition. It facilitates comparison, analysis of epidemiology and management strategies across various studies of the disease to allow us to better tackle the problem that the disease poses. And in 1996, in fact, when standardized criteria were applied to identify glaucoma across population studies, it was indeed found to be the second leading cause of blindness worldwide. So the current definition that most people use comes from a paper about 20 years ago by Foster et al., published in the BJO, which basically uses clinical criteria to define glaucoma using cup disc ratio or cup disc ratio asymmetry, and and also characteristic visual field defects with characteristic optic nerve head changes. And when that was not available, they used intraocular pressure as a criteria, or a history of blindness or surgery, or glaucoma-related surgery on the eye. This definition is pretty useful, especially in population studies where you may not have access to testing, on a wide scale. But what exactly is characteristic visual field defects and characteristic optic disc changes? Uh, in fact, many studies have analyzed this, and they have put glaucoma experts to the test, fellowship trained glaucoma experts to the test, and they found significant inter and intra observer discrepancy in cup disc ratio grading. And it must be recalled that this definition was created primarily for fieldwork and prevalence study, and it only used clinical parameters and perimetry when available. Imaging technology, which has now largely become mainstay in many ophthalmic practices, and is being currently used to determine and monitor glaucoma, has not been used to date in defining the disease. So my colleagues and I at Wilma Institute a few 5-6 years ago, when I was a fellow, we kind of decided to embark on a task of defining glaucoma a little better. We essentially created worked with experts across the globe in various glaucomological societies, and we got a consensus. And it was that basically most people felt we need to exclude, clinicians still play an important role in excluding non-glaucomatous optic neuropathy, for example, NAION, like non-arteritic ischemic optic neuropathy, high myopia-related optic nerve or macular defects that could confound HVF and OCT changes. And you need to have at least two sets of functional and structural tests, for example, perimetry and ocular coherence tomography. And the definition should be applied regardless of the patient's visual acuity or intraocular pressure. When we actually then came up with this definition, which said that either the first or the second pair of visual field test and structural OCT RNFL test should show matching defects in an eye after the clinician has excluded non-glaucomatous optic neuropathy or maculopathy, then that eye is deemed to have glaucoma. When we define it this way, we found a sensitivity of 77% and specificity of 98% when compared to the current gold standard definition of, which is essentially clinician-defined glaucoma across 13 centers worldwide, over many thousands of eyes. So this is a new definition that we have come up with, which is relatively easy to use and reproducible and relatively objective across various population groups: Indian, Chinese, Caucasian, and African ethnicity groups. An example would be, for example, here in the right eye, the OCT shows a normal OCT finding in the right eye, along with the normal Humphrey's visual field test. So that's a not glaucomatous eye. The left eye shows characteristic optic nerve head changes with inferior defects and corresponding visual field changes in the superior hemifield. An example in the right eye would be wherein the ocular coherence tomography defects in a peripapillary nerve fiber layer for the right eye, but there are no significant visual field defects for the same eye. So this would be counted or defined as possible or probable glaucoma, wherein the left eye shows matching visual field and OCT changes. So this would be an easy to use, already probably prevalently used way of detecting, defining glaucomatous optic neuropathy. This study, it must be mentioned, was done for open angle glaucoma eyes. We excluded angle closure from that particular study, and we're working on iterations to help us better define secondary and angle closure glaucoma in time to come. The current status of glaucoma, we all know, I'm preaching to the choir here. Essentially, it is a second leading cause of blindness worldwide. Top leading cause, if you look at irreversible causes of blindness. The prevalence of glaucoma in the world roughly is 3 to 4%. And what is worrying is that when we do population screening worldwide, they find that 60 to 90% of patients who are found to have glaucoma did not know that they had it, or it was undiagnosed or undetected at point of screening. About 2/3 of cases in Singapore, 90%, up to 90% in certain studies in India and China, and even 50 to 90% in so-called developed countries. And the risk factors for them not having been known to have glaucoma or not having glaucoma detected until the point of screening was age. It is higher in the older age group. But I mean, the prevalence is higher for glaucoma in the older age group, but the risk of undiagnosed glaucoma is higher in the younger age group because younger age group don't go for screening or cataract screenings and stuff like that. Men are at higher risk in some studies. Socioeconomic status of people who were deprived of easy access to healthcare, and certain ethnicities in certain countries seem to have a higher prevalence of this. So it depends on where you might be living. Unfortunately, socioeconomic status has a huge bearing on the status of glaucoma detection and prevention. And of course, patients with unilateral disease tend to have it undetected because most of us use both eyes to see. So should we be screening everyone? In 2013, the American Preventive Services Task Force did not recommend population-based screening for glaucoma because they found it to have relatively low prevalence, unlike, for example, diabetes, which has a prevalence rate of 10 to 15%. Glaucoma only has about 3 to 4%. There are low accuracy of screening tests in general, so it was not found to be cost effective. And there were potential adverse treatment effects and costs on the healthcare system if you had false positives. These guidelines are however, being revisited as glaucoma screening could be could be more effective in higher risk population. For example, those with a positive family history of glaucoma and perhaps those with known to have less access to healthcare in general. So perhaps it could be more targeted strategies. The other challenges are patient related, wherein there's a lack of awareness of the disease amongst patients. For example, patients, even when they're detected to have glaucoma, many of them do not turn up with the ophthalmologist because they feel, I'm seeing well. What are you talking about? Do I even need to see a doctor? So there's a very low follow-up rate. This needs to be addressed. There's also a shortage of skilled expertise. Once you detect them to have possible glaucoma on screening, then what? Do you have enough experts available to manage the condition? Is there adequate equipment to screen for the disease in the first place? And as we know, even amongst colleagues, one colleague, even among glaucomatologists may say, you have glaucoma and I need to treat you with medicines or put you on an SLT. While another colleague might say, no, you don't really have glaucoma. It looks like it, but it's not. So even amongst glaucoma specialists, there is a significant amount of variability as studies have shown, and you need multiple tests to diagnose, categorize glaucoma. So it is a little complicated. Can we simplify it? So you need gonioscopy, you need perimetry, you need tonometry, you need assessment of the optic nerve head, and of course you need to rule out other confounding eye diseases before you classify it and categorize it as glaucoma. Therefore, there are no large-scale national glaucoma screening screening programs as far as I am aware. There was an attempt in the US with the Student Sight Savers program, and they had very poor sensitivity and specificity with very high false positives. In Aravind Eye Hospital, if I'm not wrong, sir, I think Swati is here as well. They do screening of first-degree relatives, more on an opportunistic basis by screening those who come for. Anyone who comes through their door gets an opportunistic screening, and anyone who's diagnosed to have glaucoma are invited to bring their family members to screen for the disease. So this could be a very good strategy that could save some healthcare costs and, of course, hopefully over time reduce the burden of undiagnosed glaucoma or advanced glaucoma. Singapore as well, we're doing significant screening through fundoscopy for patients who are diabetics, who have diabetes in the primary medical care setting, and also from referrals through opticians. Our population in Singapore has a very, very high rate of myopia. So many of them do end up going to the opticians quite often. And we do get significant amount of referrals from our optician colleagues who pick up that the nerve looks abnormal or suspicious for glaucoma. So these are the current strategies that I know are going on. So ideal screening strategy should be something that is less labor intensive, better screening tests that are hopefully less operator dependent. Hopefully the screening test can be portable, and hopefully this needs to be combined with increased education of our populace and even our primary care colleagues so that we can detect glaucoma earlier and prevent the vision related morbidity better. So on the horizon in Singapore, we're coming up with various strategies to screen for the disease, right? So one example is very much in its research phase. I will go in a graded approach as to what I think are going to work. Pupilometer is one of my colleagues, Dr. Dan Melia, is looking at pupilometer, or rather the reaction of pupil to certain light waves to see whether it can pick up glaucoma at an early stage. So that could be, if it's portable, it could be very easy to detect. And they found that glaucoma causes selective loss of intrinsically photosensitive retinal ganglion cells, So right now, as you can see, the device is not portable yet, but studies have shown that glaucoma causes reduced pupil response to light compared to other diseases. And they suggest that chromatic pupillometry could be assessed as an objective clinical tool for earlier detection of glaucoma once you make it a little bit more portable. That's still very much in research phase. The next stage I'm a bit more excited about is OCT RNFL optimization. I'd like to, of course, thank my colleagues, Leopold Schmetterer, Jacqueline Chua, and colleagues in Singapore Eye Research Institutes, who are, many of us feel that OCT RNFL is very, very commonly used to help us diagnose, detect, and monitor glaucoma. But it has a lower discriminatory performance, unfortunately, in early disease, which makes it perhaps not so good for detection. And there are many, many anatomical variances in the optic nerve head, and our normative database currently is inadequate, specifically for high myopes or certain eyes with larger cup-disc ratios. So they came up with a software to optimize OCT RNFL usage, and that took into account ethnicity, specifically Indians, Malays, Chinese, Caucasians, their age, refractive error, built a larger normative database, looked at the architecture of retinal vessels in various of these categories, optic disc features like ratio, the orientation or the tilt of the optic nerve head, the foveal distance from the optic nerve head and the angle it plays to help us better detect glaucomatous optic neuropathy. And they found that when they applied this new software to currently used OCT RNFL across various machines, they found that the specificity, the sensitivity for early glaucoma increased from 59 to 71%. So this is still work in progress, but this is a very good thing that we could even use very soon. It might be an easy approach to use for people who already have OCT machines to help us detect early glaucoma and to manage it. Next one is something I need to spend a little bit more time on. I believe I have 5.5 minutes left. Essentially, artificial intelligence. This is a buzzword. It is less labor intensive. Artificial intelligence basically refers to the science devoted to making machines think and act like humans, right? So it's less labor intensive. It may resolve access to care issues. If it can bring the mountain to Muhammad, it could be more cost effective. It could be useful for both detection and monitoring of the disease. There are two main types. Really, machine learning is really what we talk about in terms of enabling computers to do tasks without significant need for explicit computer programming. And deep learning is a subset of this, wherein it enables, machine learning requires structured data, to be cup-disc ratio, certain numerical data features needs to be input into the computer for it to learn. But deep learning is a little bit more like aping the human brain, where they actually use convolutional neural networks or repetitive or recurrent neural networks to function in multiple layers to be able to process data more organically, and needs more. It can basically process fundus images, for example, without you needing to enter any data. And it takes a longer time to develop this and train the machine for this. But over time, it will deliver more data, more granularity, better output. But it is more difficult to understand, of course. An AI study in Singapore Eye Research Institute looked at using fundus photographs to detect referable diabetic retinopathy, vision-threatening diabetic retinopathy, referable glaucoma suspect, and referable age-related macular degeneration in populations, and we compared them against professional fundus photograders. And it is done across a huge database of patients from various ethnicities and various countries, as you can see in the consortium to your right-hand side of the screen. Over almost 500,000 images were processed this way, and they found that the AUC was fantastic at 0.94 with sensitivity of 96.4% and specificity of 87.2% in detecting referable glaucoma suspects in just using fundus photographs. Other studies from China have revealed a very, very similar, very, very promising results when we look at fundus photographs as well to detect possible glaucoma, upon which they are, of course, referred to the specialist for evaluation. Of course, they are looking at, AI is also looking at detecting glaucoma from optic nerve head ocular coherence tomography. In fact, if you can do it through deep learning networks, it can offer a quick and fast simplified glaucoma diagnosis with very good AUCs. We have a company in Singapore called Abyss that's working with Singapore Eye Research Institute to optimize the images we obtain through OCT, feed it into the AI network, and then give you a score, probability score of that eye having glaucoma from a scale of 0 to 100 with a very, very good AUC. So we have many things on the horizon. So if I were to summarize the AI approach, primary care providers, community optometrists in various parts of the world can then feed in fundus images, OCT images, and perimetric data into this algorithm. And this will classify it as likely glaucoma or unclassifiable or not glaucoma. If they're not glaucoma, they can be safely discharged. And if they're likely glaucoma or can't be classified, they need to be referred on for further evaluation. I think that's reasonable if we have a good structure for that. And last 2.5 minutes, I will cover treatment options. So when you do pick up glaucoma, what do you do? So we are facing this as part of my hat that I wear as the vision mission head. We look at various parts of the world that are underserved, including India, Myanmar, parts of India, parts of Myanmar, parts of Sri Lanka, Vietnam, and we look at how we can provide world-class eye care with the resources we have there. And one of the challenges we have is glaucoma. Cataract, we have a good fix for it, training programs and surgeons. But glaucoma, once you pick it up, what do you do? So we start them on eye drops, but do they come back if they live 100 kilometers away? I mean, how do you sort it out? So eye drops are the easiest way to tackle it, but it's very difficult because it needs compliance. There's a cost to it. There are side effects to it. And patients feel, I'm seeing pretty well. Why are you torturing me with eye drops? Another option is for people who are non-compliant or who may not be able to get access to regular eye drops. There are newer kids on the block. For example, Durista is now FDA approved in the US, which is a bimatoprost implant that is injected intracamerally, and it allows for long-term release, sustained release of bimatoprost with very good outcomes so far. There are other drugs in the pipeline, including travoprost and other modalities. SLT, or selective lateral trabeculoplasty, has been shown by the LIGHT trial to be relatively efficacious. It could potentially be one-off, but it's very repeatable. They are showing good results for virgin eyes, which are not being treated with open-angle glaucoma or ocular hypertension, relatively low risk of complications. But there have been complaints that, this is, are you sure this is applicable to India or to Asia? And we need to actually perform proper studies to evaluate this, like the LIGHT study has done in the UK. I think it's a reasonable option. And I think many sub-Saharan countries in Africa are looking at using SLT when they detect glaucoma to at least as a temporizing measure to stave off the disease or to control the disease in open angle eyes. And I think it's a reasonable option for people to consider, especially for patients who cannot afford eye drops or can't come for regular checkups. It's a option. Cataract surgery to cataract surgery program. So you don't just do for mature or hypermature cataracts, you do it for immature cataracts, as many Indians would classify it and doing cataract camps. It's very useful in tackling angle closure disease. It improves vision. And like Aravind Eye Hospital does, it allows you, these cataract surgery camps allow you to do opportunistic screening for glaucoma and tackle it. MIGS, minimally invasive glaucoma surgery. I won't take thunder away or steal money away from the other speakers, but it's yet to be as certain for a large scale. It has not been quite the promised land in helping us tackle glaucoma as a one-off solution. It's relatively lower risk, but you need to choose your patients appropriately. Trabeculectomy and tube surgery are traditional approaches we use to treat glaucoma, but they need good follow-up. And you don't use good follow-up, you don't take medicines after the surgery, it is difficult. Summary as I end my talk. You need better population awareness. You need to have an eye problem. You need to seek consultation. If you have a family history, perhaps you should seek consultation. You need to have more awareness in the population through public health fora, through GPs to let people know about it. You need to have a better one-stop portable screening tools. And I think AI and other methodologies are allowing us to reach that situation. We need to have better, more calibrated management strategies that rely less on patients to be able to control their glaucoma. So I think in summary, targeted and opportunity screening approach may be useful to alleviate the burden of glaucoma. New technologies on the horizon that I'm looking out for specifically are AI. I think within 5 years, we'd be using it regularly, and perhaps handheld virtual reality perimetry and OSIT on the horizon. Perhaps widespread use of SLT, this needs evaluation, and perhaps aggressive cataract surgery programs to help us better alleviate the visual burden from cataract and also do opportunistic screening for glaucoma patients so that we can restore and maintain eyesight from an early age throughout the lives of our patients. With that, I thank you very much, and I'm open to take any questions. Thank you.
Yeah, thanks very much, Jayant. Very, very informative, and of course, very dependent on technology, but that is the trend. So thanks for that very informative talk. We will take questions at the end, and I would invite Dr. Sati to deliver her talk on ASOCT.
Yeah, hi. Screen's visible?
Yes, ma'am. We can see your screen.
Yeah, a very good morning to one and all. And I would like to thank TOS as well as Dr. Vanitha for giving me this opportunity to be speaking here today. So I would be talking on the current and future applications of ASOCT in glaucoma. The anterior segment OCT is a non-contact rapid imaging device which uses low coherence interferometry to obtain cross-sectional images of the anterior segment of the eye. So essentially, we have multiple configurations that are available, starting from the earlier on the time domain OCTs to the spectral domain and the newer swept source OCTs, which give us much better resolution, faster scanning, and a deeper and wider area of imaging. Now, we all know that gonioscopy is the gold standard. However, it is subjective. It requires examiner skill and patient's cooperation. Anterior segment OCT has the advantage of being objective. It allows documentation, good reproducibility and repeatability. It requires no contact with the eye. It allows qualitative, quantitative, and morphological analysis. And you could also do sequential evaluation. So you can compare the tests that you have done today with what you did a couple of months back, a year back, and you can compare the results. Scans can also be used to show patients about their ocular conditions, especially this would be very useful in asymptomatic patients. So the anterior segment OCT helps us in visualization of the anterior segment, specific focus being on the angle, and also helps us in assessment of the bleb. So the areas where we could use this would be, first of all, in research, because this allows us to do a quantitative measurement, and this can be, with its high reproducibility and repeatability, it becomes very useful for us to use in research. So you could find out the parameters that would predispose somebody to angle closure and a host of other things that can be done. And like I said, it helps in documentation and illustration to the patient. Just as how we use the grayscale sometimes to show the patient what is happening, we can always show an open angle and the patient's angle which is closed and show the difference and make it evident to him what the problem that he's facing and the need for a peripheral iridotomy. It's also extremely useful in some cases of secondary glaucoma. And like I said, it's useful in bleb evaluation, both trab as well as post-glaucoma valve implant. Now, just a brief word about ASOCT versus the other common anterior segment imaging, which is the ultrasound biomicroscope. The big advantage with the ASOCT is that it is non-contact. So that way it is extremely user-friendly as well as patient-friendly. It does not require a skilled operator and gives us much better axial resolution than the UBM. Where the UBM scores over the ASOCT is the fact that one can visualize structures that are posterior to the iris pigment epithelium. So if you're looking at a iris cyst, which is behind the iris, if you're looking at plateau iris, in all these situations, if you want to look at effusion, then this is the area where UBM would be more useful to us. The other big advantage with the UBM is that one could perform the UBM also in a supine position, not only upright, but also in the supine position. So this would be useful when you want to do it in a child, maybe when somebody under general anesthesia. That is when you would again prefer to do the UBM. The biometric analysis of the anterior chamber angle requires a reference landmark from which the angle measurements are derived. Typically, the scleral spur is used as a reference point. In anterior segment OCT images, the scleral spur is identified as the point where there's a change in curvature of the inner surface of the angle wall, which often appears as an inward protrusion. You can also look at the location of the Schwall baseline. You can look at the intersection of the ciliary muscle and the inner corneal. So what I say is that if you just keep in your mind this kind of a picture of the histological picture, and this is a schematic picture, and if you look at the ASOCT image, you can very clearly see the area of the scleral spur in this area and how well you can see that seen on the anterior segment OCT. So it's extremely easy to identify. And this then forms the basis for all your angle measurements. Now, in an open angle, as we see on the left here, the end point. So the end point is defined as the point of the contact of the peripheral iris to the angle. Now, in an open angle, since there is no contact, the angle recess and the endpoint occur at the same point here. Whereas in an angle closure, you can see that the iris is in a position to the cornea up till this point. So the end point is seen here. The blue arrow mark here shows the end point, and sorry about that. And that scleral spur would be here. Now, this is a very useful way of measuring what we call as the iridotrabecular index. So the iridotrabecular index tells us the percentage of angle closure in an eye. So like I said, you need to identify the scleral spur, and then the iridotrabecular index can be estimated. So this has been shown to have good diagnostic performance as compared to gonioscopy for estimating the degree of angle closure. ASOCT has also been used in eyes with narrow angles, where you can demonstrate the widening of the angles post laser iridotomy. So in a closed angle, if you do the iridotrabecular contact, so here in this eye, you can see the area of contact is extending that much, and the blue area shows us the area of iridotrabecular contact. Whereas in the open angle, where you see that the angles are open, there is hardly any blue area and very little iridotrabecular contact. So this is given to us as an index and helps us to see the amount of angle that is closed in a given patient. Now, there are various biometric parameters. Now, this is a busy slide. I don't intend going through each of these, but just suffice it to say that there are multiple values that you can get. You can get the thickness of the iris, the cross-sectional area, the curvature can be measured, the anterior chamber depth, the width and the volume can be measured, the angle opening distance, the angle recess area, the scleral thickness, trabecular iris angle, trabecular iris space area. All these can be measured very comfortably on the ASOCT. The lens vault has been found to be one of the more recent parameters that has been very useful in angle closure, which is basically the distance from the anterior pole of the crystalline lens and a horizontal line which joins the two scleral spurs. So with the newer machines like the KCR2, the scleral spur is actually automatically detected by the machine, and a number of parameters are given by the machine once it has done the detection. So earlier we knew shallow anterior chamber depth and short axial lengths were known risk factors for development of PACG. With the use of ASOCT, studies have shown a classification algorithm which was based on stepwise logistic regression. They used a combination of 6 parameters that were obtained from one single horizontal ASOCT scan, and they were able to identify gonioscopic angle closure 95% of the time. So a smaller anterior chamber width, the area and volume, anterior chamber area and volume which was smaller, a larger lens vault, a greater iris thickness, curvature and area were all seen to be associated with angle closure. Here, just trying to demonstrate, that would be the iris, the lens vault, and that is the horizontal anterior chamber width between the two scleral spurs. This is the anterior chamber area, and the volume is throughout the anterior chamber. Now, coming to anterior segment OCT for assessment of the bleb, when we do a slit lamp assessment, we are only seeing the external appearance of the bleb. By using the ASOCT, we can check the cross-sectional image of the internal structures, which can give us extremely useful information. Studies have demonstrated that internal fluid-filled cavities, low reflectivity of the bleb walls, microcysts, and internal ostia are all associated with good filtration post-trabeculectomy. So in a functional bleb, you can see these large areas of fluid-filled cavity here. And in the last image here, you can see a very good ostium, the thin scleral flap here, and the path for the flow of fluid. This is a functional, good, successful trap. As versus a failed trap, you can see this, there is hardly any fluid-filled space here. The area of the scleral flap is fairly pretty much scarred, and there is high reflectivity in this area. ASOCT measurements can also be done post AGV. The bleb can be assessed post tube, and here they have shown that the maximum bleb wall was significantly thinner in the successful surgeries as compared to the unsuccessful surgeries. ASOCT can also be used, especially by using the 3D ASOCT, to guide bleb revision as well as needling. Now, just going on to a few clinical scenarios where the ASOCT has been found to be useful. This was a patient who had a silicone oil globule in the anterior chamber. Phakic patient. You can also see silicone oil subconjunctivally nasally. Now, he was doing well, pressures were fine, but one fine day he presented to the emergency department with a increased pressure, shallow anterior chamber, and headache, eye pain, vomiting, the works. So what we saw was this. There was a shallow anterior chamber. The iris was totally opposed against the cornea. We were not sure whether it was a malignant glaucoma or what was happening. We went ahead and did the ASOCT. It's much, much easier to do the ASOCT when the patient is in pain than to try and do a UBM. And here you can see that the iris is fully opposed against the cornea on the entire side. Nearly the entire length of the iris is opposed against this. And what do we see? The lens is much further behind. So the oil has moved posteriorly and is pushing the iris forward. So then we went ahead and tried to do a YAC-PI. You can see it can be difficult in this kind of a situation because the iris is opposed, but it was possible to do this. And once the PI was done, the oil came forward and you can see the iris fallen behind and the angle has opened up well. This is a patient post PK where a AGV was done, again presented with sudden increase in the pressure. We did not understand what was happening. We did a ASOCT to try and see the tube because it was not visible. This is the graft host junction where the visibility was not very good. And in the ASOCT, you can see that the tube is ending here at this point. So it has moved beyond from what it was present inside the anterior chamber. The tube has retracted, gone behind, which is why the pressures had shot up. So on this scan also, you can see that this horizontal scan was the last point where the tube could be seen. So beyond this, the tube was no longer seen. This is the tube that was seen on the cross-sectional. So we had to go ahead and put a tube extender. This was a patient with the EPCL, and you can see that this was a myopic eye, open angles. Post EPCL, there was a high lens wall. The anterior chamber was shallow. There was forward bowing of the iris. So these are the older type of lenses where, so that's the closed angle and the increased lens wart. So with these older lenses, the openings are in the periphery. They're not in the center as in most of the newer ones. So that had got blocked. And so there was a pupillary block that was happening. A PI was done. You can see the opening here and you can see the increase in the angle width as well as a decrease in the lens vault. Another case, a young lady who presented with a sudden increase in the pressure, shallowing of the anterior chamber, pain in both eyes, and developed a myopic refraction. Yes, you guessed it right. This was a topiramate-induced glaucoma. And you can see that the ASOCT is showing the closed angles. You can see a choroidal effusion on the ASOCT. You can see that here. And you can also see the supraciliary effusion on the ASOCT. Patient was taken off. That's the closed angle.
Madam, since we are running short of time, I would request you to please sum up in next 30 seconds. So
Sure.
Sorry for the interruption.
Here, done. So post-treatment, stopping the topiramate and giving steroids and cycloplegics, the angles opened up, the effusion resolved, and the ciliary effusion resolved. So just a word about the future applications. We are looking at angle closure prediction models that would probably give us a likelihood index for angle closure. 3D ASOCT could play a pivotal role in guiding glaucoma management in bleb revision and needling. And we could have polarization sensitive OCT, which could help us in detecting potential antifibrotic treatment for blebs. So it's a rapid objective method to image the anterior segment. It's a very useful adjunct. It cannot replace gonioscopy. It helps us in understanding the underlying mechanisms for various types of glaucoma. Thank you.
Thanks very much, Sati. I'll just move on with my talk. We will take questions at the end. Right. So I'm actually going to talk about scope of MIGS in the developing world, and I have no relevant disclosures related to this talk. So conventional surgery in glaucoma is bleb-inducing glaucoma surgery, or BIGS. And we all know that trabeculectomy is the mainstay of treatment, and an ideal trabeculectomy bleb, as we all know, should be low versus high. It should be diffuse versus localized, and should be posteriorly directed rather than anterior. But we are all aware that it quite often goes pear-shaped, and you end up with a failed bleb, as well as a lifetime risk of blebitis or bleb-associated endophthalmitis. Then we have the glaucoma drainage devices, which also produce a bleb around the plate, well away from the limbus, as you can see here. They do have good IOP reducing potential, but as you know, hemoglobin valve or valve devices have hypertensive phase up to the tune of 80%, and slightly less so in non-valve devices. Therefore, the coinage of and the description of the newer minimally invasive glaucoma surgery. And what we're going to talk about is its relevance in countries, middle income, low to middle income countries like ours. Is there, or can there be, a paradigm shift in management? Now, MIGS were predated by cylindrical device Express, but they are several in number, newer, safer options in glaucoma, and can be used earlier on in the disease. And there are various devices. How do you actually classify them? Based on where you're placing them, perhaps in the trabecular meshwork or canal base, where you can stent them, you can dilate, or you can also do an otomy. You can remove a piece of the trabecular meshwork, or in the suprachoroidal space. Then there are some blood-forming ones, which are not strictly mixed devices, but they are available, as well as ablative procedures. And I'm going to talk to you about endocyclophotocoagulation. And like I said, the trabeculotomy section is what is available in India right now. But I'm very pleased to inform you that the iStent and iStent Inject has now received DGCI approval, and Swati and myself are part of a small group of glaucoma specialists who are actually going to work to collect real-world data in India related to this device. So when we compare the two, mixed procedures, they reduce surgical time, complications, they're cosmetically more acceptable, bring about more rapid visual recovery, and can be combined with cataract surgery. But the most important factor is that they do not compromise the conjunctiva. So if you need trabeculectomy later, you can still do it. What is the flip side? That so far they have mostly demonstrated modest reduction in IOP, and they are not usually indicated in angle closure unless the angle opens up post LPI, and cost is an issue. So therefore, role of MIGS is possibly evolving and can be offered to patients undergoing cataract surgery or who are on 2 or more anti-glaucoma medication. This will, I believe, help to eliminate issues of non-compliance, non-adherence, which is a big issue related to quality of life, as well as ocular surface problems. We are all aware of these kind of pictures: dermatitis, surface disease caused by medication, and dramatically improved picture once the drug is withdrawn. And of course, we are also very aware of these kind of very red eyes caused by anti-glaucoma medication. So what are the challenges in the developing world? There are limited resources, including that of skilled resources, poor uptake of healthcare services by the stakeholders, usually delayed presentation. And when that happens, the disease is very advanced. And of course, we have more morbidity related to angle closure disease than we do related to open angle. So I present to you a few characteristics of what MIGS should be in the developing world, that it has to be efficacious and efficacious with less side effects. Now, this is a universal requirement, not just in the developing world. Should be cost-effective, blebless if possible, be suitable for advanced disease, and be suitable for all etiologies of glaucoma, including angle closure. So in the Indian context, what we have available, as I said, are procedures which lead to partial deroofing of the Schlemm's canal, like the trabectome or the Cahook dual blade trabeculotomy. Trabectome will be presented by Dr. Sanita. I will show you a video on Cahook dual blade. Then GAT, or 360-degree ab interno trabeculotomy with suture, will be presented by Swati. And I will talk about endocyclophotocoagulation after the brief presentation on trabeculotomy, KDB trabeculotomy. It is a standalone blade with two cutting edges. It deroofs the Schlemm's canal, and the same effect can be achieved with a bent 27 gauge needle, the so-called BANG procedure, or bent ab interno needle goniectomy. So a brief video on Cahook dual blade.
Trabeculotomy. Cahook dual blade is a single use ophthalmic blade which utilizes ab interno approach through a clear cornea micro-incision. Dual blades are positioned for precise parallel incisions of the trabecular meshwork with minimal residual leaflets. Visualization of the angle structure. A direct gonioscope is placed over the cornea to identify the structures in the angle. This is then lifted to aid entry of the Cahook dual blade in the AC, and the blade tip is placed into Schlemm's canal before advancement. Blood reflex is often noted from collector channels after the KDB excises the trabecular meshwork. Tip of the KDB. Minimum of 3 to 4 clock hours of trabecular meshwork in aggregate is excised, about 90 to 120 degrees. Irrigation aspiration is used to remove already free floating or attached to the.
Right. Moving on to endocyclophotocoagulation, it is, of course, an infrared diode laser, cyclodestructive in nature, has the advantage of direct visualization when you deliver the laser compared to the transscleral. Here in this particular case, you can also see the zonules, only because pseudoexfoliation is also present. Otherwise, you do not see it. Usually only 1/4 the power of transscleral delivery is required, and it can be used irrespective of angle status. Slight disadvantage is that requires a sterile environment when you compare it to the transscleral delivery, and it is best combined with cataract surgery or in pseudofix or afix. When you're using it standalone, you can either enter corneal or pars plana, and when you do pars plana, you need a limited vitrectomy. Complications mostly are CME, fibrin, and hyphema. So, endocyclophotocoagulation in angle closure disease, is it for real? I will show you a brief video again on the procedure in acute angle closure once the pressure and the inflammation was controlled, and you can see how dramatically the picture changes. So I put an intra-op gonio on before phaco, and you can see that there are no angle structures visible. The cataract surgery then is completed as per usual. And once it is completed, I place the gonio again, intra-op gonio again, and I still don't see any structures visible. So I place the IOL in the bag, and then cohesive viscoelastic is placed in the sulcus, and the ECP is set up, and the 19 gauge curved probe is inserted into the sulcus, and laser is delivered to the tip of the ciliary processes, so-called endocycloplasty. And you can see the tip receding from the angle. I introduce the endoscope once again into the anterior chamber, and now, lo and behold, you can see scleral spur for the majority of the inferior angle, with some peripheral anterior synecdoche still present, as demonstrated by this picture here. And this is followed by, washing of the viscoelastic and closure. No suture is required. So we have published phacoendocycloplasty with trabeculectomy in angle closure disease, and preoperatively both groups were very well controlled. Postoperatively also, both groups were very successful in reducing intraocular pressure, anti-glaucoma medication, and in improving vision. But when the two were pitted against each other, phacoendocycloplasty reduced the pressure to a slightly greater extent, but this was not statistically significant. Neither was the need for anti-glaucoma medication, nor was the complete success on Kaplan-Meier. So what was it that separated the two? Was actually the complications between the two groups, as well as the interventions required, which was much less in the phacoendocycloplasty group, and this was statistically significant. And please note that aqueous misdirection was fairly commonly occurred in the phaco-trabeculectomy group. When I compared phaco with phacoendocycloplasty, phaco alone that is, again, the groups were very well matched. The AC depth was slightly less in the phacoendocycloplasty group, but both procedures were again, phacoendocycloplasty was very efficacious in reducing IOP and medication. However, phaco alone only reduced medication, not IOP to the extent that phacoendocycloplasty did. Again, here you can see that this was statistically significant. So the complete success was statistically significant in phacoendocycloplasty group. And again, aqueous misdirection raised its rather ugly head in phaco alone group compared to phacoendocycloplasty. And here's this case of a shallow AC preoperatively with 3 mechanisms of angle closure. She became deep only because she underwent iridozonular hyaloidovitrectomy during surgery, phaco alone, to control her AC depth. And so if I summarize the points from the 3 studies that I have done on phacoendocycloplasty, complete success about 75%. It is superior to phaco alone, non-inferior to TRAB, no sight-threatening complications. And as we know, when you have multiple mechanisms, you are predisposed to aqueous misdirection intra or postoperatively. Endocycloplasty helps to deepen and stabilize the ACD, and so you can avoid aqueous misdirection and iridozonular IZHV. Now, I gave you this checklist. Phacoendocycloplasty seems to check each one of those characteristics, except perhaps cost effectiveness. But if I were to talk about us doing phaco surgery now, or phaco femtophaco, we would still be in the era of intracap surgery if we did not believe that phaco was superior to intracap surgery. So mixed procedures have brought about a paradigm shift. There is potential for treatment earlier on in the disease, eliminating non-compliance, non-adherence, ocular surface problems. There is, of course, enhanced safety. Current procedures, unfortunately, are only for open-angle glaucoma, usually combined in cataract surgery, mild to moderate glaucoma. GAT has the potential to be the primary surgery for primary congenital glaucoma, and ECP of all appears to have the most comprehensive indication. However, there are extremely limited data in Indian eyes, and it is possible that conjunctival sparing procedures will be preferred, with TRAB being the last recourse in such patients. Thank you very much for a patient listening. I just want to give you the story of this patient who presented to me after her combined surgery all the covers of her drops with a smile. So that was a very powerful message for me, that even though she was not on very many medication, she was well rid of them. Thank you very much.
Thank you so much, Dr. Vanitha, for the wonderful and insightful session. Moving on to the next session, I would like to invite Dr. Sunita Dubey. And she'll be presenting her talk on current and future applications of trabectomy. Over to you, ma'am.
Just sharing my screen.
Sure. Yes, we can see your screen.
Okay. So I would like to thank Dr. Vanitha, Dr. Santosh and Toss for the kind invitation. I'll be speaking on current and future applications of trabectome. So if you look at glaucoma management spectrum, especially for primary glaucomas, for most of our patients, we start the treatment with medication and then probably laser, though not necessarily. But the option of incisional surgeries is exploited pretty late for the obvious reasons that though they have very successful outcomes and we have been performing those surgeries for pretty long, but some of these procedures like both trab and tubes may be associated with sight-threatening complications in some of our patients. So mixed, mostly conjunctival sparing may offer reasonably high safety profile. So it can be proposed earlier if needed in mild and moderate glaucomas. Especially when you're performing cataract surgery, you can combine one of the mixed procedure and also reducing the need for topical medications and its ocular toxicity. As Dr. Vanita has just said, that medications may be associated with a lot of sensitivity and toxicity leading to non-compliance. So they can be classified, as has already been discussed, based on their physiological mechanisms and anatomical site of action. And in India, now we have started some of these procedures, especially ciliary body procedures and procedures related to Schlemm's canal and trabecular bypass. If you look at the anatomy, the trabecular meshwork and inner wall of Schlemm's canal, they offer the site of maximal resistance. The Schlemm's canal drains to 25 to 35 collector channels, which are maximally concentrated infero-nasally and which is mostly the site where we perform the trabectome or other mixed procedures. And then the aqueous is transmitted to the intrascleral and then to the episcleral venous plexus. So trabectome is the oldest FDA approved mixed device, and it targets the site of maximum resistance. It's a standalone device and it utilizes a controlled plasma-mediated ablation system. And as you can see here, it achieves complete removal of diseased trabecular meshwork and Schlemm's canal inner wall. As you can see here, this is the trabecular meshwork. And after performing the surgery, the trabecular meshwork and the inner wall of Schlemm's canal is removed completely, and you are seeing the collector channel opening. And since it is an excisional goniectomy, as opposed to the incisional goniotomy, which is done mostly for pediatric patients, it minimizes the chances of scarring and reocclusion of collector channels as the remaining edges of the TM are far apart. So I think this point is very, very important, because if these remaining edges reapproximate, the chances of failure and fibrosis are there. And also it has this special insulated foot plate, as you can see here, which helps guide the electrosurgical tip and also protects the adjacent tissue, especially the outer wall of Schlemm's canal and the collector channels. I think, again, that's very important. And when you are learning any mixed procedure, it's very important that you maintain the anterior chamber, and it is formed all the time so that you can see the trabecular meshwork or the angle. It's very important to have good visibility to facilitate removal of the tissue debris and blood reflex. So I think I find the advantage with this trabectome, that the maintenance of chamber is there all the time. So it can be used in most forms of glaucoma, and I have done in almost all forms of glaucoma, open angle types mainly, primary, secondary, adult, and even pediatric. And it is very effective in pseudoexfoliative and pigmentary glaucomas. And studies have now shown that it is even effective in severe glaucomas, in the sense that if the pressure is very high, the reduction of pressure and the reduction in number of medications is pretty good. And in narrow angle, of course, after PI, when the angle opens up, or you can even do some amount of goniosynecholysis with this. It is can be performed with cataract surgery and also as the standalone procedure. And the other like along with trabectome, you have trabex and trabex plus which are not the standalone devices, but Trabex is like KDB blade with serrated edges, which helps in complete TM excision. And Trabex Plus has the advantage that you can connect it with any phaco irrigation aspiration system. So you don't have to even have a standalone trabectome device. You can have this and connect them on any phaco machine because they're compatible with the phaco machine. Now coming to surgery, I think it's very important to know the intraoperative gonioscopy, which is pretty different than what you perform in your clinics. And so first and foremost is to learn the gonioscopy intraoperative, and then setting up the position and setting up the microscope. Microscope is tilted towards the surgeon and the patient head away from the surgeon, making approximately the angle of 70 degrees, as you can see here. Now, just showing this animation video, you can see this. There's a 1.8 millimeter clear corneal incision, and the viscoelastic is placed on cornea. And then again, you need to verify the angle so that you identify the angle while performing the procedure. And this is the probe, which has this irrigation from the sides and aspiration at the tip. And this is the tip with electric electrode and return electrode, which performs the ablation and the foot plate. So once you identify the angle, you just start ablating from one side. So from the center, you just go on one side as far as you can move your hand and you're comfortable, and then rotate the handpiece in the opposite direction and then perform it on the other side. So it's very important to identify the trabecular meshwork. And when you make the incision and decompress the eye, sometimes you see this reflux of blood, and that helps you to identify the trabecular meshwork. So you identify the trabecular meshwork, give the incision 1.8 millimeter, and then enter with your probe, as you can see here, and identify the trabecular meshwork. As you have the constant irrigation, the AC deepens and you can easily identify the angle. And then you see this deroofing of the Schlemm's canal and ablation of trabecular meshwork, and you can see this white line suggestive of the outer wall of Schlemm's canal. So you can just keep moving your gonioscope and perform do the ablation as far as you can. And when you can combine it with phaco, the advantage is that the time you take for performing phaco, the bleeding or the reflux from the collector channel stops by then, and at the end of surgery you don't get any reflux, and there's no risk of hypema post-operative. So at the end of surgery, it looks like as if you have done cataract surgery. So now coming to these studies, it is backed by a lot of clinical studies, almost 120 peer-reviewed articles. And this is the first decade of trabectome surgery. They studied almost 4,600 patients, and first 20 cases of the surgeons were analyzed, and the success criteria was IOP less than 21, at least 20% reduction in baseline IOP, and no additional glaucoma surgery. So there was 66% success in trabectome alone after 90 months, and 85% success in phacotrabectome after 60 months. And this is the meta-analysis, and it shows that trabectome reduces IOP by approximately 36% at the end of the last follow-up. Studies have shown that it even works after failed trabeculectomy, and that the collector channels do not atrophy. And it is comparable to AGV and even Barwelt implant, and the results are similar in terms of reduction in intraocular pressure and reduction in the number of medications. And the patients which were studied were matched in terms of clinical diagnosis and the stage of the disease. I just would like to share our data, 58 patients who completed at least 1 year of follow-up. And All types of diagnosis were included, and it was done as a primary surgery in 89% of the patients and a secondary surgery in 11%. And trabectome combined with phaco in 42% and trabectome alone in 58%. And I even operated severe glaucomas, and this is the result. The percent reduction of intraocular pressure was pretty good. It was better in trabectome alone because the baseline IOP was more. However, the phacotrabectome maintained the IOP for a longer time. So this was almost 36% reduction in trabectome alone group, and number of medication reduction as well. So survival analysis, while individuals undergoing trabectome with phaco, there was 88% survival at the end of 1 year and 67% survival for trabectome alone. It is specifically effective in patients and safe in patients who have safety issues with trabeculectomy especially. And this was a 44-year-old male myo with pigmentary glaucoma. He underwent trab with mitomycin C in one eye with chronic hypotony, and you see the bleb here. And so left eye didn't have advanced glaucoma, and you can see here there's removal of pigments after trabectome, you can see, and maintenance of pressure. Another patient with congenital glaucoma, 5-month-old child, and she was operated both eyes for trap plus trap. And the right eye did pretty well, and the bleb was there. The axial length and corneal diameter stabilized, but the left eye, the axial length kept increasing, and corneal diameter also was increasing. Even after needling, the condition was not stable. So as you can see that there was high iris insertion, and I had done trap plus trap in this patient. So I just tried to do this trabectome, and you can see this unroofing of the Schlemm's, this white line. So just to conclude, so it is effective as a secondary procedure. So I think it's important to choose appropriate candidates, learn proper gonioscopy, watertight wound closure, and post-operative management. So trabectome definitely has a future, and I think it is easy to learn procedure, especially when you're performing or entering into this area of performing mixed procedure. And the greatest advantage of any mix is that you can preserve conjunctiva for future surgeries. And however, in India, we need more evidence to decide the best option for each glaucoma patient. Thank you very much.
Thank you so much, Sunita, and thank you so much for sharing your data as well. We will take questions at the end. So I now invite Dr. Swati for her talk on suture GAT.
Thank you, ma'am. I'll be sharing my screen now. Is my screen visible, ma'am?
Yes.
Okay.
It is, Swati. Go ahead.
Thank you, Anita, ma'am, and Santosh, sir, and Telangana Ophthalmic Society for giving me this opportunity. So I'll put it on slideshow. Suture GAT, is this the preferred option for angle surgery in India? And I'll be presenting my data for that. I have no financial interest. And as Dr. Vanita has already told about all the classifications of mixed procedures, and as Sunita ma'am has already told that trabectome is the oldest one, which was approved in 2004 for use. And we have iStent, which has got now approval, iStent and iStent Inject, GAT, Kahun dual bait, as covered by Dr. Vanita. So I'll be talking about some of them. So the available options for angle surgery are trabectome, KDB, bang, or GAT. Now we'll look into each one of them. Trabectome approved in 2004, and as Dr. Sunita has shown in her video, that it ablates the trabecular meshwork. So what are the logistics involved? The machine costs around 25 lakhs, single-use tubing, with a one probe costs around 52,000 Indian rupees. The probe can be cured, but the tubing is just one-time use. And the degree of angle that can be treated is around 120 degrees and at the max 140 degrees. So what do you think? Kahook dual blade, similarly, it also takes away, it just tips the tip pierces the trabecular meshwork and it stretches the tissue as the devices advance, and it tears away the trabecular meshwork. Now the logistics, there are many studies showing that Kahoot dual blade is also having good, if it's an effective procedure at reducing intraocular pressure and medication burden. But the logistics, it costs 1 kdb costs around $450. It is not yet approved in India and it cannot be re-sterilized. And again, the degree of angle that can be treated is only 120 to 140 degrees. Bent ab internal needle goniectomy performed by 25 gauge needle or 27 gauge needle, as you can see in the video. So I have bent the tip of the 25 gauge hypodermic needle and it just becomes like a low cost version of KDB. You introduce the tip into the Schlem's canal and then you proceed on one side. After you have done around 1 to 2 clock hours on one side, you turn the tip and then you proceed in the opposite direction. Why can't you use a 26 gauge needle? Because it is too small to reach the nasal angle, and a 24 gauge needle is too huge for the trabecular meshwork and it can cause cyclodialysis. So this is a low cost version of of KDB. So now the logistics involved. 25 gauge needle costs around just $1. It is affordable, it is single use, but the degree of angle treated is again 120 to 140 degrees. Now comes GAT, gonioscopy assisted transluminal trabeculotomy. Developed by Davinder Grover and Ronald Feldman in 2014, it cannulates 360 degrees of the Schlemm's canal, either by passing an eye-track microcatheter, which is not yet available or approved in India, or the low-cost version is using a 50 Prolene suture. Instruments used for GAT are low-temperature cautery, Schwann-Jacob gonia prism, 50 Prolene, a 15-degree side port knife, a cohesive viscoelastic, 25-gauge MVR blade, microsurgical technology MST forceps, and a McPherson forceps, and to confirm the presence of suture in the canal, an indirect gonio lens. The prerequisites are proper patient selection, as told. MIGS are mostly for open angle glaucoma cases. Intraop gonioscopy, as told by Dr. Sumita, very, very important for starting MIGS. Keep the head end of the head end elevated, that the head should be above the heart level, which will reduce the bleeding from the Schlemm's canal, and keep cohesive viscoelastic with you. So this is a video showing suture guard. I'm blunting the tip of the suture. Normally I blunt both the ends of the suture to make it a little mushroom. So this is just to compare that it should not be a very big mushroom, because the trabecular meshwork or the Schlemm's canal capacity is not so much. If you have a very big mushroom, you can cause a false passage. Make a paracentesis to introduce the suture, and then another paracentesis to introduce our MST forceps. Put ample amount of cohesive viscoelastic inside the anterior chamber and then introduce the suture from the side port. Remember to direct the suture towards the 3 o'clock or 9 o'clock position depending upon the eye. Put a dollop of cohesive viscoelastic on top of the cornea. Tilt the microscope towards you and the patient's head away from you so that you can easily see the nasal angle. Put viscoelastic again and then see the angle. As you can see beautifully, these sclerals spur, the trabecular meshwork, the ciliary body band. Now with a 25 gauge MVR blade, you have to make a limited goniotomy. This is the posterior wall of Schlemm's canal, the white line which I am showing. Using MST forceps, you have to grab the inserted part of the suture and then gently put it inside the goniotomy which you have made, and keep proceeding. Keep giving little thrust to the suture so that it keeps on proceeding inside the Schlemm's canal. Now for the beginners, if we don't know whether the suture is in the Schlemm's canal or not, we have to use indirect gonio lens, which I'll be showing in just a moment. Once the suture reaches 180 degrees, it will be difficult for us to push it very easily. You have to give real hard strokes when you reach 180 degrees so that it passes the opposite direction. I mean, it crosses the 180 degrees. This is an indirect gonio lens, where I'm showing that this is the blue color suture in the Schlemm's canal. So the color of the suture also helps you in identifying its presence. So as you can see, it has reached till one point of time, one place. Okay, so now you get an idea that how far you have reached and how far you are still to go. This is the suture which I am showing that has reached the other end, but it has still not come to the initial goniotomy side. So just keep pushing it. You can augment your anterior chamber depth using cohesive viscoelastic in between also. So gently you have to keep on putting a little more force for it to appear at the opposite side. Now it has appeared at the opposite side. Just grab hold of the tip above the suture which you have introduced earlier. Otherwise, your suture will get locked at 180 degrees. Now, when you have caught the suture end from the other opposite side, using a McPherson forceps, you have to just pull it outside. So that will cause the ripping away of the inner wall of Schlemm's canal. And your suture gap is done. Take away the viscoelastic by doing bimanual irrigation aspiration and then proceed with your phaco. In the end, to prevent reflex from the, because you have opened 360 degrees of the Schlemm's canal, there you expect a blood reflex on post-operative day one. So inject and leave a little bit of orogel or Helon GV inside the anterior chamber to tampon at the bleeders. So there are studies done by Dr. Davinder. They have published their preliminary results. They have published their 24 months results, and they have shown that GAT is effective, safe and effective procedure in both reducing intraocular pressure and the number of medications. And also it is as good as the ab external trabeculotomy studies. Now, the intraoperative challenges are the first stroke is the best stroke. So keep the things ready and localize the trabecular meshwork intraop gonioscopy. Now, I'll be showing some tips to reduce bleeding from the Schlemm's canal. You have to keep the head above the heart, lift the operating end of the table, and this reduces the reflux on the Schlemm's canal, and use heavy elastic OVD. To avoid false passage, you should have a proper understanding of the angle structures. So you should not blunt the tip of the tip into a big mushroom. It should be just blunted. And confirm with suture presence in the Schlemm's canal using an indirect gonio lens. Intraoperative tips like suture is not advancing, then maybe confirm that it is in the Schlemm's canal. Then if it is going into a false passage, then you have to retrieve it back and try from the opposite side, which is a twin side GAT. If you have shallowing of anterior chamber, you have to use OVD, and the gonioscope should be placed just gently. These are some of the post-operative pictures where you see that there is hyphema. I think I had hyphema in 21 eyes of 21 eyes out of the 27 eyes I operated, but it usually resolves in the first post-operative week. So if you have hyphema, previously you should do a pre-op counseling. Form the anterior chamber with Helon GV or Orogel and keep it 30% fill. And it is normally self-resolving. Either use pilocarpine BD for 7 days or alpha agonist BD for 7 days. If you have a false passage, if your suture has gone into a suprachoroidal space, you can have a choroidal detachment. Then you can deal with it with systemic steroids, topical steroids, and this is a post-operative POD 15 picture where it has resolved completely. So I'll be showing my results. 27 eyes of 26 patients we had operated. Mean age was 62.4 years, 19 males and 7 females. And I operated on POAG 18 patients, 4 normal tension glaucoma patients, 4 pseudo-exfoliation glaucoma patients, and 1 angle recession patient. So we had a lot of moderate glaucomas. We have majority of advanced glaucomas because mostly these were like palliative surgeries where I thought I'll do, and then we got good results with that. So the pre-operative vision was 1.19 logmar, which improved to 0.45 logmar. But the thing is, on post-operative day 1, there is a reduction in visual acuity because 21 out of 27 eyes had microhyphema or layered hyphema. So there is a little bit of apprehension between the patient as well as the doctor, but ultimate goal is achieved. So complete success was achieved in 75% of the patients. Pre-operative AGM were 1.29 and they reduced to 0.35. Regarding vision, pre-op vision, I have told, intraoperative pressure, intraocular pressure, 24.7 millimeters of mercury plus minus 9.21 was the pre-operative, which reduced to 6.18 plus minus 7.4. So the complete success was achieved in 20 eyes, that is 75%. I did have intra-op complications and post-op complication. The most common post-op complication was microhyphema or a layered hyphema and choroidal detachment, as I showed in one case. So the GAD logistics, the low temperature cautery is reusable and it costs around $100, but it can be used for 20 cases. So cost per case comes to be $5. One Crowley sutures costs around 450 INR or $6. But one suture can be cut into 8 to 9 segments of 5 centimeter each and can be used for 9 cases. So cost per case will be 50 Indian rupees. So the overall GAD suture GAD can be done in less than $10 per patient. So India, we have to choose the best option. Kahoot dual bait, 450 USD, not yet approved. Zengel implants, 1,500 US dollars, not yet approved. Trabectome approved, but 1,000 US dollars. And one probe costs around 52,000 rupees. And cost of eye stent is also 1,500 US dollars, but it is still waiting to be imported in India. And eye track catheter, not yet approved, but 750 US dollars. So the best option is suture guide, which is less than 10 US dollars. So to conclude, I would say, yes, suture CAD should be considered as the preferred option for angle surgery in India because of its effectiveness, its low cost, and 360-degree trabeculotomy. Thank you.
Thank you very much, Swati, for that very spirited defense of suture CAD. We all agree it is effective, but we obviously need more data, and we need more data in all the other procedures as well. There is absolutely no doubt about that. The preliminary results are definitely very encouraging, I should say, in Indian eyes. So I don't think we have any questions from the audience, and we don't have much time either. But I just wanted to ask a question each, maybe to all the speakers, especially start with Jayant. Are you still there? Hello?
Yes, Anita, I'm here.
Yes. Hi. Yeah,
yes.
Thanks for staying with us.
Of course.
You talked about targeted screening. All the procedures and the devices that you're talking about, are in the pipeline. Not many are in use. So what we can do at this moment in time is perhaps targeted screening. And as you pointed out, and as we all know, Arvind Eye Care has that unique institutional spread that can achieve that. But what do you think each glaucoma specialist could do?
I think
in this regard,
I think actually only some of them are in the pipeline. Some of them are already now being used. Like AI is actually being actively used in Singapore. We are rolling it out, and I think very soon you're going to see its applicability, especially if you can use data from fundus images, OCT, and or HVF for visual field changes. I think you would be able to scale up glaucoma screening at a very fast rate. And in fact, we are looking at a pilot study, hopefully in Orissa, in the center you and I go to, wherein we're looking to optimize use of OCT in screening everyone who comes for cataract. So we're combining opportunistic screening that Arvind, for example, does with a bit more ubiquitous, a bit more use of OCT, funneling it into an AI software algorithm, and then out of that, picking up 5 or 10% of the eyes that might need further evaluation. So I think it's actually going to come to use very soon. I'm excited about it. Then with regards to what you can do now, I think anyone who walks through the door gets a screening in terms of tonometry, in terms of visual field. In terms of looking at the optic, this unfortunately had to depend on subjective this ones to first pick it up. And then subsequently targeted use of visual field if you need to, or ocular coherence tomography if you need to. So everyone who comes in your door gets that. And in Singapore, we have a very high rate of angle closure. So we do gonioscopy for everyone. Nice talk on ASOCT. And many of the papers quoted were from Singapore. We still use gold standard clinician, even in Singapore, even though we do all those studies. Ultimately, for now, gold standard is still clinician, for right or for better or for worse. ASOCT is to help us in arbitrating those plus minus. Ultimately, we still rely on gold standard for now.
Absolutely.
Anyway, yeah.
So the question to Sati that I have is, has ASOCT assessment of the angle replaced gonioscopy in your center?
No, that's a big capital no. In short.
Okay, so I was really glad that you underpinned that it cannot replace gonioscopy as of now, but is a very useful adjunct. Thank you very much. Sunita, I was going through your presentation. Maybe I missed it because I had to take a washroom break. You talked about very impressive IOP reduction, definitely. But what about the anti-glaucoma medication reduction?
Yeah, actually, I had talked about that also.
Okay, sorry.
As as you had in my series, I think almost 1/3 of the patients had advanced glaucoma, and they were on multiple medications. So most of the patients were on some medications, especially of the advanced glaucomas. So the number of medications had reduced from I think from 3 point something to 2.8. So the number of reduction of medication was by 1. However, I had noticed that the IOP was very high. The baseline in patients who had very high baseline IOP, the pressure reduction was much more as compared to the patients who had less, baseline IOP. So,
right. Thank you very much. Sadly, we are out of time, but I really thank all my speakers for a wonderful, wonderful presentation in their sphere, with such relevance, not only to today, but for the future as well. Thank you very much. And Diksha, are you there? We're on time for the next session. Thank you. Bye-bye.
Thank you, ma'am.
Thank you.
So much.
Take
bye.
care.
Have a good Sunday. Bye-bye.
Perfectly. We are perfectly on time. Sorry, I was speaking and I was on mute. Very comprehensive talks by all our esteemed speakers and beautifully moderated by Dr. Vanitha. Thank you so much, Dr. Sunita and Dr. Sati, for chairing the session. And thank you so much, Dr. Jayant, for coming all the way from Singapore virtually for the session. With this, we conclude the session. But before that, I would like to take the opportunity to thank all the delegates present here. And since we are a one big happy family, let's hear it for all of us present out here. So I would request everyone to please unmute your lines and switch on the camera so that we can hear it for all the speakers present here. And let's have a huge round of applause for all the speakers. Amazing. Great. All right. So with this, we conclude this session. This is your virtual host, Diksha Rana, signing off. We'll meet again at Dr. S. Badrinath Hall at 2 p.m. sharp with the next session. Thank you. Have a great Sunday.